I would like to toss off to our first presentation, which is very exciting. It's a unique presentation. It's a unique CME that we can offer through Roper St. Francis. We've been able to have the Serious Illness Conversation CME for the last 3.5 years. And many of us have taken advantage of this learning and process. I did it about 3 years ago and really did learn a lot of information, but found that, I'm not using it as intended. And so we thought that even if you've gone through the training, it would be good to have a refresher and to look at the ins and outs of this process. Dr. Joseph Ritchie is the head of this team that will be bringing this CME to us. Initially, they started as a very small group, 2 or 3 participants learning with role play. Then COVID came and they had to pivot to a virtual medium. And now we've even asked them to expand to even a larger audience. So there will not be the one-on-one training that we've had before, but he does have an opportunity for those who are interested to do further training. And he'll discuss that in his talk. So without further ado, Dr. Ritchie.
Good morning. Good morning. Thank you all so much for participating. I know there's probably nothing else in this world we'd rather be doing than talking about advanced care planning at 8 o'clock on a Saturday. So thank you for joining in. Again, I'm Joe Ritchie. I'm a physician. I'll be joined soon by Dr. Chris Hawk and Dr. Haley Carter for the second portion of our conversation this morning. But we're here today to talk about serious illness conversations and advanced care planning. The objectives of our session together are described on this slide. You can read in front of you. We'll go through these briefly. We'll start off by describing the evidence-based benefits of having these conversations for patients and their families. We'll describe your role as the clinician in improving serious illness conversations. Then we'll pivot and focus on the actual components of a serious illness conversation guide itself. And we'll spend time breaking down the conversation line by line and learning some pearls on how to navigate these conversations. And then for the second portion of our session this morning, we're going to identify communication skills techniques within the guide itself that are best practices. So again, an agenda, how this will break down, really is going to be 2 portions of our talk this morning. The first is going to be more of a didactic, where I'll go through, introduce the concept. We'll have a brief reflection here at the beginning to kind of set the stage. Then we'll focus on the evidence-based rationale for having these conversations and even outcomes that other health systems have seen when they implement a care program like we've done here at Roper. We'll pivot at that point to focus on the conversation guide itself again, the rationale and the flow of the conversation. We'll take a quick break at that point, let you get some more coffee in you and rest a little bit, come back. In the second portion, we hope to be more interactive. So again, myself, Dr. Hawk, Dr. Carter, we'll be doing some interactive role play with practicing these conversations in different clinical scenarios. And at that point, we'll ask for your feedback. We'll ask you to put comments in the chat. We hope that part of our talk will be more interactive. We'll be stopping and starting and getting your feedback as we go through that. And then we'll wrap up at the end with the debrief about where we stand at the moment and kind of next steps that you as the clinician can take to move this work forward. All right, so to start us off today, I want you to pause for a moment and try to think about a patient encounter that you may have had or a patient you may have cared for. Goodness, could even be a family member that had a good or bad outcome at the end of life, and how that may have been related to communication with their medical team, whether that was good communication or maybe not the best communication. And if you can, just think about these situations, these scenarios, and as you think about one that you may have experienced, I'm going to go through one that I've written down. This is one that is more common from palliative care type scenario, but we can all imagine a gentleman in his 70s has known metastatic lung cancer. He's also got COPD, goodness, may have had strokes in the past with AFib, and he finds himself in our ER with a few weeks of failure to thrive, more falls at home, now bedbound, so quite sick. We do a workup, we do labs, we do images, and we find a pneumonia, and the scans also confirm what we know, that he's had brain mets. Again, actively on treatment up to this point. Our patient is confused, he's encephalopathic, unable to provide history or speak with the medical team. And the family's with us at the bedside, and they're really unsure as to what to do at this point. They say, well, we may have had these conversations in the past. In fact, I think Dad filled out an advanced care plan that we should have been provided to the primary care doc, but we really don't know, and we certainly aren't sure of what's in the advanced directive. And they're really unclear as to what level of treatment burden their loved one would be willing to go through. And so appropriately, the ER reaches out to the ICU to come evaluate and to figure out what treatment options exist and where we could go. So again, this is a very broad story and certainly no outcome from this scenario, good or bad. But I want you to maybe compare this story to one that you may be thinking of, or a family member you may have had. Because there's a few pitfalls here that I think are important that we need to focus on. And there's a lot of room for improvement within our health system, all health systems, to maybe help this scenario go a little different way next time. A few of the things that I would point out is, well, goodness, maybe this gentleman has had these conversations and they were provided even in writing to one doctor. Well, how do we communicate that across platforms? How does that go from a primary care doc to an ER, to a hospital? Another key point here is, well, this gentleman, I know I made this scenario up, but he's got a known advanced cancer with brain mets. And so you ask yourself, well, goodness, are we a little late in the game to have these conversations in the ER in a moment of a crisis? And could we have had these conversations sooner? And so what we know is there's three themes that come up when we discuss advanced care planning. And there's three areas for improvement. And they focus on the frequency of these conversations, when they happen in someone's disease course, and then the scope of the conversation itself when we do engage in these conversations. And so let's break those down for a moment. So infrequent, so fewer than a third of patients with end-stage diagnoses report end-of-life discussions with their clinicians. And so we know the majority of patients with serious illness just aren't having conversations at all with their medical team. When they do happen, we know that they're late. So in one study, it showed that patients with advanced cancers, the first documented end-of-life discussions were a month before their death. And of those, 55% occurred in the hospital setting. We know in this acute setting, these aren't as productive. We know that we do this conversation much better upstream, out of the hospital, when patients are feeling well. And then when we do have them, we know the current state of affairs is that they're very limited. So conversations often focus on procedures, right? So do you want CPR? Do you want a ventilator? Do you want artificial nutrition? And we often miss the bigger picture about what matters most to our patients. So I think a much more valuable conversation would be focused on what's important to you. What are you worried about? What's your support system look like? How much does your family and your loved ones know? And so the current state, again, as we know, as we've shown here, is that these conversations are infrequent, they're late, and they're limited. And so what can we do to address this? What can we do as a health system to try to move the needle in a meaningful way in these three areas? Well, here at Roper St. Francis, what we've done is we've implemented a serious illness care program to address this. You can read here the mission of our work is to improve the lives of all patients with serious illness by increasing meaningful conversations with their clinicians about their values and priorities. And again, throughout the morning, you'll hear us say this over and over. The focus of this work is values, priorities, wishes. They're not specific about treatment preferences and resuscitation status. They're much more meaningful conversations. So our care program has been developed over the past 3.5 years. It started from gracious funding through the Duke Endowment Grant. And it represents a collaboration with a partner from Boston, and it's Ariadne Labs, who's helped provide some key tools for our program to be successful. And so when we talk about our program, there's really three main levels of the program itself. One is patient-focused, or patient-facing, which is our tools. Today, we're going to talk a little more in detail about one tool in particular, which is a conversation guide for doctors to have with their patients, but there's other tools we have available. Tools for patients to be prepared for these conversations, tools for family to be prepared to engage with their loved ones before visiting with their doctors. Another level of our program focuses on education, so like we're doing today, talking about the importance of this work across the health system. We also offer one-on-one skills session practice with clinicians to practice these conversations before they go back in their clinics and have these conversations. And then the third level of the care program is a systems level focus, which is how do we work with doctors and clinicians, practices on coming up with strategies to screen their patients. How do we create workflows within their clinic to help remind them when patients come to see them that, hey, this person's got a serious illness. We may want to take some time to engage with them about what's important in their life. Again, how do we train the doctors and the clinicians to then carry out the conversation? And importantly, after that, how do we help document? So how do we create templates that these conversations can be placed in the EMR so that it can be translated across different clinics and different platforms? So those are, again, the three areas of focus of our care program. Today, we're going to focus a little more in on the specific conversation guide itself, but please know that the program has much more to offer than just this one conversation we'll focus on today. So what about other health systems who've implemented this type of serious illness care program? Well, what they've seen is that early conversations about the patient's values and goals have been linked to better care. And so what does better care mean? What is that qualitative point? So we have shown that it's increased goal-concordant care. It's improved the quality of life and patient well-being. It's led to more and more appropriately earlier appropriate utilization of resources, so things like hospice care, fewer hospitalizations. So if a patient doesn't want to spend time in the hospital, especially at end of life, we need to know that. We can limit that treatment burden that they have to go through. And ultimately, these conversations and having a structured approach to care delivery for these patients have led to better patient and family coping. And so what do we know about the standard right now across the country and across health systems? Well, what we know, if you look to the right of this slide, is that less than a third of clinicians have any system in place to go about engaging with patients in a meaningful way. I think more importantly than that, less than a third of clinicians ever had any formal training to begin with. And so there's a big lack of knowledge base about how to have these conversations. How do we practice? How do we train to actually engage in this work? And so the downstream effects, which we can imagine, are very understandable, or less than a third of patients with serious illness are actually having these conversations. And so how do we think of a system redesign? And this is a visual slide to kind of depict the goal of a care program like ours. So how do we help the system come up with ways to select patients, screen patients within the clinic, prepare them for these conversations with their clinicians? How do we train the clinicians again to have the conversations, remind them to have the conversations in their busy work life? And then ultimately, how do we create a system that we can document this and share this across multiple specialists and people that may help care for these patients? Well, again, one way to do that specifically is to have a standard, high-quality approach to the conversation itself. And so to do that, we utilize this serious illness conversation guide. And I know on this slide it's much too small to read. We're going to break it down in detail here in a few minutes. But the takeaway is that this is a conversation that fits on one page. It's a framework for serious illness communication, psychologically informed, patient and clinician tested. This again was work that's been done through Ariadne Labs. It's been revamped over 100 times. There's been a lot of work and thought put into creating this conversation guide, and it's designed for early conversations. And other health systems, such as Dana-Farber Cancer Center, have implemented this exact tool within their patient cohort. And in fact, they did a large study where they randomized patients into an interventional group and a control group. The intervention group had this conversation with their clinicians compared to the control group that had just standard of care. And when we look back retrospective and the patients that had gone through this study, you can see some of the outcomes here. And again, these themes are recurring themes that we've already started talking about. So 89 versus 44% of these patients had documented conversations in their EMR about values and goals. And so much more high quality end-of-life discussions. 90% versus 45% had documented prognosis in their chart. We know this is such a key data point to share with our patients, and it really anchors all decisions in the framework for conversations based on honest, frank conversations about what's ahead in their prognosis. And then we know that from this one study that patients who had been deceased with serious illness, these conversations typically were happening 144 days prior to their death compared to 71 days from the control group. And so again, higher quality, earlier, more often. Again, these themes that we know are lacking in the current state of affairs. And so how about the patients that went through this study? What were their feedback? What did they have to say about having these conversations with their doctors? Well, 2/3 of these patients reported that they received just the right amount of information, and the conversation happened at just the right time. This is a really important piece to share with clinicians. You know, one of the biggest anxieties we have as the physician is, you know, am I having this conversation too early? I don't think my patient's prepared. I don't want to surprise them. I don't want to go somewhere that they're not ready to go. But we know the overwhelming feedback is these patients value this conversation and tell us that, no, that was just right. You know, I was ready to have that conversation. It was right at the right time. And then when we do have the conversation, 55% of patients reported that their closeness with their clinician increased as a result of the discussion. That's a really powerful thing to share, that there's an intervention that we can train ourselves to do, to share with our patients, and over half the time it improves the rapport and the trust that we have in that relationship. And then 2/3 of these patients reported positive behavioral changes as a result of this discussion. Again, objective changes, outcome changes because of having these conversations with their clinicians. And some of their specific comments we can read here. You know, they typically fell into some categories on the left side of the screen. So people gave feedback about practical planning, changes in how they communicated with their family, how they did end-of-life care planning, their well-being. You can read some of these specifics here. So it helped make changes to my will, plan my funeral. I'm more realistic about the approach with my family and friends about my prognosis. You know, looking through some of these more, you know, I'm doing the same amount of stuff I was before. I just feel less anxious about the future. And this is that framework that the conversation helps us with, that, you know, hoping for the best but preparing for the worst. And then the last one here, I always like to highlight because, again, I really value, if nothing else, having these conversations with our patients. We get the feedback here. Mostly the conversation just brought me closer with my clinician. And so if nothing else, this is a tool that can help build that trust and that relationship. And that's not only helpful, we know, for our patients, but it's helpful for us, you know, as the clinician, in terms of satisfaction, burnout. These are difficult, you know, situations. We don't want to be the bearer of bad news. We don't want to have to care for people that we know are going to get sicker, but, you know, having this intervention can help build that trust and build that relationship with our patients. So we've been doing this work here at our health system for about the past 3.5 years. And so what are some of the feedback that we've been getting? We just talked about some feedback, you know, from other health systems, but what about our own Roper St. Francis patients? And again, this is a very busy slide, a lot of comments. We don't have to go through all of them. I've highlighted some of the key takeaways, and I hope you'll see some of the recurring themes that have been shown in other cohorts. You know, it really gave me great insight into what's ahead, brought things into reality, made sure my family knows about my care wishes. Again, enhanced my relationship with the clinician, helped us get on the same page, reinforced our wishes, my wishes. I feel how all this impacts me personally, not just physically as a human being. And then as we go to the bottom, basically this just made me feel better. And so that's a really valuable feedback. These are patients in our own community, and some of the feedback that we're getting right now today from people, again, that are under our own health system at the moment. And so a great comment we got from the clinicians that go through this training was here. This conversation creates space for the unspeakable to be spoken, which alleviates a weight for my patient and for me. And so that's a really profound way of looking at these conversations. And so more specific feedback that we've gotten from clinicians who have gone through these training sessions and who have engaged in this work with their patients. Now I have an easy and complete way of giving and documenting the conversation, again, improving the patient satisfaction. I now feel more comfortable in initiating a difficult conversation. Makes me look for opportunities to have the discussion, even when I'm not the doctor managing the serious illness. So this is really important feedback. Right now we have such a kind of fragmented health system that patients often have multiple specialists. Some may be networks, some may not. We lose sight of who really has ownership over sharing bad news or talking about the future. If our patient's suffering from cancer, we may think, well, the oncologist really needs to be having that conversation. They've got heart failure. Well, the cardiologist really needs to be the one to go down that road. So how do we have a tool that can standardize the approach to these conversations, whether we're an oncologist, a cardiologist, a primary care doc? Again, how do we lift that quality of the conversation so wherever the patient falls within our health system, we know they're getting a high quality goals of care discussion. Other things that we've seen, the conversation will help me initiate the conversation itself. It's less stressful setting, and it's good for the outpatient setting. I hope that's a key takeaway today for our outpatient clinicians. It gave me a better communication tool and techniques to be more comfortable in having these conversations. And again, a lot of similar themes here and feedback that we see from our clinicians. And with some leadership, we've done some focus groups about implementing this work within their clinics and their feedback of how this work aligns with the mission of our health system and what we do in terms of healing all people with compassion, faith, and excellence. Again, we won't go through all of these, but this is some of the feedback we've gotten from some of our leadership. This last one, our care delivery model and field of work aligns us with the mission of the health system. These conversations are difficult, but they're ingrained in our culture and how we interact with patients. And that's the key that we hope that this work aligns with. This is the culture that we have in our health system, that this is the standard of care. If you have a serious illness and you're cared for a clinician within Roper St. Francis, we expect to be able to engage in these conversations and honor and respect your wishes and priorities. And so we'll pause at this point. At this moment, we've set the framework for why these conversations are needed. We know that right now advanced care planning is infrequent, it's late, and it's not that high quality. We know that Roper St. Francis has taken steps to try to address those things by implementing this serious illness care program. We've seen some feedback that other health systems received when they implemented serious programs. And then we've started to see some feedback that our own system is seeing with patients and clinicians who have gone through these conversations. And so we're going to, again, transition now to focus specifically on, well, goodness, what is this conversation? What are we talking about? How do we go about getting these outcomes? And so we're going to take a moment and focus on this one tool, again, that is the foundation of our program, which is our Serious Illness Conversation Guide. And again, this conversation is a framework for best communication practice. It's been retooled and revamped over 100 times. It's been patient tested, and it's a very concise one-page conversation, and we'll go through the structure here in a moment. But it really leads us step by step on how to have a thoughtful conversation so that we're not just kind of making this up as we go. And we like to think of the guide as a recipe at first. And so you can imagine any time you're going to make a pie or cake, whatever it may be, the first few times you do it, we really encourage people to go step by step, line by line. Truly just read the guide, read the questions. We want you to feel comfortable doing this before you start making it your own, before you add the more sugar or you cook it longer, shorter, whatever it may be. And as you get more comfortable with it, you certainly don't need that recipe anymore. You do it from memory. You make it your own. But we really want to encourage people to normalize actually using the guide itself, just reading the questions with our patients. And so how do we start? And so we first start with a setup. So this is a really key point to get this conversation off the ground. We have to introduce the idea of why do we need to have this conversation. And importantly, after we share why we need to have it, we have to ask permission to then have the conversation. And this is a really key point, and the guide is very intentional. There's multiple points throughout the guide that we ask for permission. We need to leave room for patients maybe not being ready in this moment to have that conversation. And we need to ask so that we don't surprise patients or ask questions that may catch them off guard without knowing who needs to be here with them. Maybe it's a loved one. Maybe it's they're just not ready that day and are willing to have it in the future. Maybe they need to prepare before they come back and have this conversation. But we need to also train our clinicians and be ready to describe the benefits of having these conversations and to defend why it's important that we do this, because this may be a little different than what the patient's used to in terms of their interactions and their encounter with their clinician. So again, I'm going to read the question from the conversation guide itself. This is a little wordy in the first few times you do it, and which is why we encourage people to go through the practice sessions, because you really need to get comfortable with this verbiage. But the concept is, I'd like to talk to you about what's ahead with your illness and do some thinking in advance about what's important to you so that I can make sure we provide you with the care that you want. Is that okay? Again, we describe why we need to have this conversation. I want to ensure that I take the best care possible for you, and I need to talk about what's ahead with your illness. Again, is that okay? Allowing permission for someone to say, I'm not quite ready, not right now. If the patient is willing to have the conversation and say, sure, let's talk. The next step of the conversation guide leads us to really exploring what the patient understands about where they are with their illness. And so this is done through an assessment. And it's a statement about illness understanding, and then a statement about information preference, how much the patient wants to know or wants to be engaged. And I'll pause at this point because this is a key concept in any goals of care conversations or advanced care planning. We like to think of it as a house model for shared decision making. We think of it as a picture of a house with a foundation, 2 walls, and a roof. And the roof is our care plan. The roof is our shared decision making and the decisions that we've made with our patients. But to get to the roof, we have to start first with this foundation. And so that's going to be our rapport with our patients. So the trust that we have, the ability to engage in these conversations, and our patients to feel that they're in a trusted relationship, that we can come up with a care plan that's in their best interest. One of the walls to our house is the medical facts. So these are our scan results, our blood work, the stage of our cancer, the severity of our heart failure, COPD, whatever it may be. This is the reality of what we're looking at. The other wall is what the patient and their family understand about their illness. And you can imagine until those 2 walls are level and equal, we can't expect to put a roof on the house and to make that decision or help make that decision with our patients about a pathway forward. And so we have to assess how much they understand. We have to bridge that gap in knowledge of where they are and what the facts are. And we've got to get on the same page before we ever can realistically take that next step and talk about where to go from here. And so we do that with nice, short, open-ended questions. So what is your understanding now of where you are with your illness? What a beautiful, simple way of just opening the door for the patients. Tell me more about what you're hearing. Then that leads us into how much information about what is likely ahead with your illness would you want to hear from me? Most people, when we ask this question, would say, Doc, anything I want to know. What do you mean? Is there something you need to share with me? They'd be very open. They want to know everything that the medical team knows. But this question is important because we can imagine some patients don't want to be engaged in that conversation, or want their loved one to really lead that conversation. Doc, I try to stay out of this. I rely on my spouse to make those decisions. Whatever they think's important, I would go along with. Or you can imagine a patient with maybe dementia, right, or someone that maybe lacks the capacity. Understanding how much they want to be engaged and want to know is an important step before we overwhelm them with information that they may not be ready for or may not want to hear. And so once we've set up the conversation, the next step in the conversation is delivering prognosis. And so this is the framework for the entire conversation. And so this is, to me, the most key fundamental aspect of the conversation. This is where, as a clinician, you are sharing with the patient some sort of prognostic disclosure. And we think, when we think back to prognosis and how we're taught, we're often reflect back on prognosis equals time. That, to do prognosis, I need to be able to say you have this many weeks, months, years of life. But at the same time, we know that we're horrible at that. That's the worst thing for patients. We're often wrong. In fact, if any clinician tells a patient with certainty how much time they have left, I promise they're wrong. So what are other, maybe more meaningful ways to share prognostic information that's not as fraught with anxiety from being wrong or just being, sharing wrong information? And so the two other tools that the guide gives us are verbiage about functional status and language about uncertainty. And so the guide itself gives us these three options to deliver a prognostic statement to our patients. And so we'll go through these each individually. So the first one, again, time. One of the things we'll focus on in the second part of our discussion this morning when we're actually practicing using the guide itself is a technique about these wish-worry statements or these hope-worry statements. And the guide has that communication technique buried or embedded within it. And so you can see the first one here, this wish-worry statement with time. So I wish this weren't the situation, but I'm worried that your time may be as short as weeks, months. I wish I could sit here and tell you that you could be here for your trip at Christmas. I'm worried that your time may be short and you may not be alive at that point. Again, I personally use that one less often. And I know there's a lot of anxiety with clinicians about being wrong about time. And so what are some other meaningful ways we could do that? Well, one that is very powerful for someone would be a prognostic statement about their functional status. Again, buried within this guide is this hope-worry kind of sandwich verbiage of, I hope this isn't the case. I'm worried, though, that this may be as strong as you feel and that things are likely to get more difficult in the days ahead. You can imagine using this in so many different scenarios. In fact, in the hospital, we use this a lot when patients are acutely ill and may find themselves at a new baseline. But hearing that carries so much prognostic weight, right? As a patient, you just were told by your medical team, goodness, what if this is as strong as I feel for the rest of my life? What if this is as functional as I'm going to be? That's going to help reframe the conversation from this point forward. Another way to do that is more broad and vague verbiage that really is applicable in almost any scenario with a patient with serious illness. And this is that hope for the best, prepare for the worst type verbiage of, it's really difficult to predict what will happen with your illness. I hope you continue to live well for a long time, I really do. But I'm worried that you could get sick quickly. And I think it's important that we prepare for that possibility. Again, this hope, worry, anchoring and aligning yourself with your patient. I hope that this isn't the case. I hope you get better. I'm here for you. I want to help you get better. But I'm worried what we know about your illness, that may be unlikely. In fact, you may get sick quickly. So again, the guide gives us these three options to figure out, based on our patient and their scenario, which one do we need to use to share our prognostic worry with our patient. And this is the point of the conversation that we need to expect and we need to be prepared to elicit emotional responses from our patients, right? Anytime we share prognosis, we really need to give room for an emotional response, for an empathic statement. And let that sit in with our patients and let them contemplate what we just shared. And so the most important thing we can remember to do at this point is to slow down and breathe. So truly using silence as an empathic way to communicate with another human in the room. So we really encourage our clinicians when they go through these practice sessions to be very intentional and stop after you share a prognostic statement. Breathe, calm yourself, recenter yourself. Be prepared to follow that up with, what are you thinking? That's a lot to hear. What's going through your mind right now? I'm going to be here with you every step of the way in this journey. That's got to be really overwhelming to hear. Some patients are very sad to hear that. Some form of an empathic statement to be able to help support our patients at this point. Because that prognosis we just shared is again going to set the framework for all the questions that we need to explore with our patients. And I belabor this point about prognosis being so important because you can imagine if you sit with a patient and you look at them in the eye and say, hey, Mr. Smith, what's most important to you? You could get a whole wide variety of answers, right? They could tell you what's most important, that I live to be 100, that I go do these things, that, these lofty goals, these big picture hopes and aspirations, and that's beautiful and it's great to know and to explore with the patient, but we may have a little more meaningful conversation that can inform our medical decision-making and care plan if we ask, I'm really worried that this may be as strong as you feel. Based on what I just shared, if this is as strong as you feel, what is most important that you do with the time that you have left? So again, it frames our conversation on a prognosis that we just shared. It makes these questions have more meaning based on what we just told the patient in terms of our prognostic worries. And the specific questions we ask revolve around these themes. What are their goals? What are their fears? What are their strengths? The verbiage in the guide are very short and sweet, open-ended questions. What are your most important goals if your health situation were to worsen? What are your biggest fears and worries? What gives you strength as you think about the future? So a few things to highlight at this point of the conversation. Again, we encourage you at the beginning to truly read these questions out loud. But we know everyone is going to have their own flavor, their own ways of asking. You may use different verbiage. For example, I stay away from the word goals when I talk with patients. I think it can be confusing often, and I think maybe a more meaningful question is, what's most important to you if your health situation were to worsen? So that's just one example of how me personally has used this guide but adjusted it to my own liking. Another thing to highlight at this section of the guide that we're really proud here within our health system is this third question about what gives you strength as you think about the future with your illness. And so this question was actually added to the guide after some pilot studies were done here in Charleston in our own backyard with our African American community. The feedback that the Ariadne Labs received from that cohort when they used this conversation guide with them years ago was the conversation lacked a question that could elicit their responses about their faith and their faith-based community and their support system in terms of their spiritual health. And based on that feedback, this question was added to the guide. And so, again, we're really proud to highlight that and think that's a really unique stamp that our health system has placed on this conversation guide to make this more meaningful for all patients, not just ones here in Charleston. The conversation then continues to explore critical abilities, trade-offs, and family awareness. Again, these are questions that we may not have asked so explicitly in the past, and without a conversation guide itself. I know I would ask these questions, but maybe not in such straightforward ways. And we can really elicit powerful responses, again, when we have a structured way of approaching it, so we don't miss these things when we talk to our patients. So what abilities are so critical to your life that you cannot imagine living without them? Again, sometimes patients will look at us with a funny look and say, abilities, what are you talking about? Tell me more, I don't understand that question. And so we'll practice this in our session here in a moment. But another way of asking that I find a very powerful way of reframing this question is, what are the things in this world that give you joy? What are the things that you could not imagine being so sick you couldn't continue doing, that give you happiness, give you comfort, peace? And you can really elicit some pretty remarkable responses to that and learn so much about our patients that we may not have ever explored before. I had a gentleman once tell me about how he was a woodworker and spent his time in his shed building furniture, and how he could never imagine being so sick that he couldn't be functional enough to use his saws and use his material. And again, that helped us come up with a plan to prioritize his functional status and his independence. As we look through the conversation guide, the next question on our list is, if you become sicker, how much are you willing to go through for the possibility of gaining more time? So I hope you see in this conversation, nowhere in this guide is verbiage that you would find otherwhere, like an advanced directive about like artificial nutrition or code status or mechanical ventilation, right? These questions are much more open-ended. A surrogate for that is seen right here. How much are you willing to go through? You know, if someone does have strong feelings about treatment preferences, they would certainly could offer that here. You know, doc, I would never want to go back to the hospital. Or last time I was in the hospital, that was really awful. I never want to go back to the ICU. I would or wouldn't want this. You know, this chemotherapy has really been tough on me. You know, I'm not sure I'm willing to do that anymore because of the side effects, whatever it may be. But again, we let the patients dictate what they want to respond and how much they want to share by asking these open-ended questions, rather than specific granular questions about, do you want a ventilator? Do you want CPR? And then the last explore question in the conversation is, how much does your family know about your priorities and wishes? So this is a really key fundamental part of this conversation. It's how much, you know, it's great for you to be able to share with your doctors, your medical team, what's important to you, you know, what you would want to prioritize as you got sicker. But goodness, if you lose the capacity to speak for yourself or to advocate for yourself, who is going to honor that and respect that? Who's going to be your voice when you can't speak? And so this last question helps us understand that as a medical team. Who's your family? Who's your support system? You know, we can tool the verbiage of the guide based on what you know about the patient. If they have a significant other or no spouse or no children, you know, family is kind of a loaded term. So you can use whatever it may be. You know, who loves you in this world? Who's your support system? How much do they know about priorities and wishes? So we wrap up the conversation after exploring those questions that we just went through with a recommendation. And so this is where we get to put back on our clinician hat and really use the information that we just heard, that we just learned from our patient, to come up with a next step. And what are we going to do based on all the information that our patient just shared with us? So how do we summarize what we just heard? And how do we have a recommendation about where to go from here and how this is going to help with us delivering care for our patient? And then ultimately, how do we wrap up this conversation by affirming our commitment to our patient? And so you can read the verbiage that the guide gives us. So I've heard you say that blank is really important to you. Keeping that in mind and knowing what we know about your illness, I recommend that we blank. This will help us make sure that your treatment plan reflects what's most important to you. How does that sound? And then ultimately, I will do everything I can to help you through this. You know, please know your team is here with you every step of the way. You know, lots of different ways to wrap this up, but some sort of statement of commitment of, we're here for you, you're not alone. Your medical team is going to honor and respect what's most important to you. And so, you know, we take a step back and all of that we just went through fits on one page and is a very straightforward way of making sure that we set up the conversation, we assess how much our patients know, how much they want to know. We anchor the conversation on some sort of prognosis and prognostic disclosure so that we can frame the next questions. Then we explore what's most important to our patients. We use that information to close the conversation and come up with some sort of recommendation as their clinician. And so all throughout this conversation, you'll see things that we can offer in one-on-one training sessions to help with pitfalls and pearls and ways to help navigate this conversation, whether it be, you know, how do we help clinicians respond to emotion? How do we help normalize asking for permission? What do we do about clarifying questions? How do we demonstrate active listening to help transition from question to question? How do we use bookmark statements? So there's some things that we offer in our training sessions with clinicians to be able to dive deeper and to practice these conversations before clinicians go out in the community and have these conversations with their patients. And so this is going to be some of the areas of focus for our second portion of our session this morning, where again myself, Dr. Chris Hawk, Dr. Haley Carter are going to be role-playing this conversation. We're going to be stopping and starting. We're going to be highlighting these areas, some teaching points, and we're going to be demonstrating for you all what type of one-on-one training our program offers to you. Some of you may have already even gone through some of these sessions, but we wanted to, again, demonstrate that for the big group today. And a key takeaway we hope at the end of this is that this is something you're interested in and you'd like to participate in. We'll talk at the end about how we can set up one of these sessions so that you too can practice. All right. So to take a step back, again, we've gone over the guide itself. We've talked about the rationale behind why we need a structured system in place to have these conversations. We've already seen some outcomes from other health systems, but more importantly, I think outcomes from our own backyard, from patients and clinicians at Roper, St. Francis that are going through these conversations. And so now we're ready to take a quick break, get some coffee, take whatever you may need, so that we can regroup and then actually practice using the guide and see what this looks like in real time. And so we also are going to pause before we do that and make sure if you have any comments or questions from what we've gone through that we can talk about those before we break here. And so I know we have our chat function, and we've got our moderators here with us that can help read questions you all may have. So please take a moment if you do have questions or if there's anything we went over you want to highlight, drop that in the chat. We'll take a moment to go through those before we take a quick break.
Good morning. Dr. Ritchie, we did have a question in the chat box wanting to consider what type of patient to have this conversation with. What's considered a serious illness, and specifically Alzheimer's?
Certainly. That's a great question. I appreciate you all asking that. You know, part of our program is tailoring these conversations to each clinic, to each clinician, and what's right to them. And so how a heart failure clinic may screen their patients may be very different than how an oncologist screens his patient, and certainly may be different than how a primary care clinician screens their patient cohort. And so, you know, we encourage doctors and clinics to come up with their own process. We've got some recommendations for what other clinics have done. The easiest, kind of most broad way to screen a patient cohort is with what's known as the surprise question. And so this is a validated tool to ask a clinician, would you be surprised if this patient passed away in the next year? So again, a very broad, open-ended question. If the answer is no, I wouldn't be surprised, then that screens that patient into this serious illness cohort without needing to know anything about their COPD, their FEV1, their EF from their heart failure, or how many admissions they've had to their hospital. Just a very broad screening tool. Other clinicians like to be much more objective. And so how do we create a system within our clinic that maybe can flag patients that come in to see us based on their functional status, based on their utilization of the ER or hospital visits? And so again, we work with different clinics to come up with whatever screening tool works best for them that they can embed within their structure, their workflow. And there's no one right solution. You know, Alzheimer's, we heard mentioned Alzheimer's specifically. How do you engage in these conversations with someone with dementia? And so one of the comments I would say there is the conversation guide is meant to be used with caregivers as well as our patients. And so there are times where these exact conversations and questions are had with loved ones rather than the patient themselves if they can't engage in the conversation. But how you would identify a patient with Alzheimer's as more seriously ill than others in terms of the disease trajectory, we could come up with different tools. There's a fast scale that scores Alzheimer's disease severity. There's functional status scores that we could use to help work with you. And so again, we'd really tailor that to make sense for you and your clinic based on your experience and your expertise. These are your patients. So we really look to the clinics to guide us into what makes sense for them.
And then I have one more question.
Yeah.
How would you share this information after you have this conversation with other clinicians?
Absolutely. So we alluded at the beginning of that's a big systems level pitfall in advanced care planning in general and goals of care. So how do we have this wonderful, meaningful conversation in the primary care office, but then they wind up in an ER or the oncologist, some other specialist clinic, right? How do we translate that? Well, some of the strategies that we've created within our health system are creating templates to document this conversation. So within ECW, within Cerner, we have now conversation templates that are these questions, and you document the answers. The conversations live and they're filed under advanced care planning tabs. And so if you go to screen for advanced directives, EMS DNR forms, post forms, you'll see the serious illness conversation guide in that bucket as well. And so we've created these templates to help put these conversations in the right bucket within the EMR. Some of our earlier work focused on health informatics exchange platforms. So within Charleston, how do we use these external platforms that could pull data from MUSC, Roper, Trident into one EMR so that we could share this information across health systems. And as y'all know, with the upcoming transition to Epic, a lot of work has been going in on the front end to how do we build these templates so that in our new EMR, again, they're accessible across inpatient, outpatient platforms. So a lot of different strategies. Again, this is a really difficult, broader issue just than advanced directives. I mean, it's a larger health systems issue that we're trying to, hopefully with our program and our project, we can come up with tools that can be solutions for bigger issues as well. But that is a very key pitfall at the moment, and it's really important to highlight that that's a big limitation of a fragmented health system.
So I do have one additional question that has come in.
Yeah.
How long does this conversation typically take? And is it something that takes a whole visit, or is this something we could just wrap up a visit with?
Yeah. So that feedback is one of the number one questions we get. And we hope when we practice the conversation, you can see firsthand how long these conversations take and what they entail to complete them. I'll kind of just spoil it and just share that typically we tell people that these conversations are about a 10-minute conversation. So that's kind of the goal is, can we wrap this up? Can we get through all of the steps in about 10 minutes? And that being said, these are billable encounters in terms of advanced care planning, counseling of patients. And there are add-on codes that we can use in the outpatient setting and in the inpatient setting that are time-based on engaging in serious illness conversations with our patients. A caveat to that is that these are typically 30-minute add-on codes, and over half of the 30 minutes need to be spent on counseling, with the remainder of the time spent on documenting and putting in the templates. And so for that 30-minute add-on code, it would require 16 minutes of face-to-face time with the patient. So if we're going to use that billable code, the kind of magic number is 16 minutes of a visit. But in real time, as we'll demonstrate, we really want to show you all that these conversations are quick and efficient when we use a guide. They certainly can not belabor the point, but we can go off track, we can go down rabbit holes, and they can take much longer if we don't use a structured format to stay on target. But 10 minutes is our goal. And we hope that can, because of those 10 minutes, that we can ingrain this work within primary care workflow and their all busy schedules of how do we add that into your already scheduled visits? Do we change a 15-minute visit to a 30-minute visit that day so that we can carve out some time to do this? Or how do we maybe have an entire visit dedicated to this, a 15-minute visit that's the goal of the visit? And so again, these are strategies we work one-on-one with clinics and clinicians in terms of strategizing with them of what makes sense to their busy schedules and their clinic workflow.
Great, thanks. We do have some additional questions that have come in, but what we're going to do is go ahead and take our 10-minute break now. And then we're going to address some of those questions as we get back after we see the actual conversation.
Well, welcome back. Thank you all so much for coming back to join us. We're going to transition at this point to our second part of our session this morning. And what we hope to show you today is we're going to demonstrate what having these conversations look like in real time. We're also going to highlight the skills training portion that we offer through our serious illness care program and how we can role play to help train clinicians to engage in these conversations. And so I'm joined by Dr. Chris Hawk, who's going to be our patient for our first interaction. Again, I will be the clinician for our first conversation. I would like to ask you all in the audience to focus on these key areas as we go through it. So how we work on setting up these conversations, how we focus on prognosis, how we focus on addressing emotions, and then ultimately the recommendations that come out of these conversations. And so just to kind of level set, explain this situation we're going to do, we're going to have multiple different clinical scenarios. For the first one, I will be the physician, Dr. Hawk will be our patient. We'll rotate roles and we'll add different scenarios as we go through. And again, we want you all to see that these are the sessions that we offer, again, on one-on-one training with clinicians within the health system. And so this is going to be an example of what our role-playing sessions look like in real time. So for our first session, we'll set the stage as a primary care follow-up appointment. I'll be a primary care clinician. Dr. Hawk will be a patient with COPD. We'll set the stage as the last year has been more difficult with 2 or 3 hospitalizations, now on continuous oxygen for the past 6 months, and just having a little more difficult time in terms of strength, doing things that he likes to do around the house. And in fact, we'll say that maybe you were recently in the hospital, and this is a 2 or 3 week post-discharge follow-up visit in the clinic. And so that kind of sets the stage for us this morning. And you'll see me again be the clinician, and we'll go through how this conversation looks. Does that sound fair?
It's fair.
Okay. All right. So Dr. Hawk, thank you so much for coming back to see me today in the clinic.
I'm glad I'm up to coming. You know, the last time I was in the hospital was pretty rough.
I cannot imagine. I'm so sorry to hear that. I'd like to take a little bit of time today, if it's okay, and talk about that and talk about what may be ahead with your illness. I know it's been a difficult last year for you.
You know, I think I need to know what's really going on.
Yeah. Well, one of the things that I'm doing now with all of my patients is I'm going through this questionnaire and this conversation to make sure that I know what's most important to you, and we can do our part and to take care of you the best as possible. So you may see I'm going to look down and ask some questions to you just to make sure I'm not missing anything. Would that be okay?
That'd be fine. Don't leave out any of those steps either.
Certainly. You'll keep me honest. Well, I'm just going to start here with the first part. And so I'd like to talk about what's ahead with your illness and do some thinking in advance about what is important to you so that I can make sure that we provide you with the care that you want. Is that okay?
Yes.
Okay. So do you mind sharing with me what is your understanding now of where you are with your illness?
Those cigarettes were not good for me. And, you know, I've had COPD for longer than I've known, but I've learned how to carry around the oxygen. But I would say that I'm not snapping back as quickly when I come out of the hospital as I used to. And this last time it's kicked my butt.
Goodness. Well, I know you've always done such a great job of coming back to clinic and listening to our recommendations to try to best take care of you. And I know you're doing everything possible to try to stay well and stay out of the hospital. But that's got to be really overwhelming and tough to feel this way.
It has been tough, and you're right that I have tried to avoid it because, my pulmonary doctor tells me that the exacerbations are what really sets you back. So that's kind of discouraging too.
That can be scary. Well, how much information about what is likely ahead with your illness would you like to hear from me?
I think I would like to know as much as you're willing to tell me and as much as you know, because, you know, it's all hard to process. When you're in the hospital, there's so much going on. It's just really hard to figure out where you are when it's time to go home, except you're going home today.
Yeah, kind of catch you at surprise. Well, you know, I want to share with you my understanding of where things are with your illness. And it can be really difficult to predict what will happen with your illness. And I hope that you continue to live well for a long time. But I do worry that you could get sick quickly, like we've been seeing recently. And I think it's important that we prepare for the possibility that you could get sick quickly.
You know, you never want to hear that. And I guess when you had it as long as I have, you expect the hammer is going to fall sometime, but you still don't want to hear it.
What's going through your head? What are you thinking about?
I'm thinking about what do I need to do in whatever time I got left, and how much time do I got left?
Well, I appreciate you sharing that with me. Please know that that's what we're here for. And that's what your medical team is here to help you with. Talk through those things and support you. And what's going to help us do that is making sure we understand, again, the best way to take care of you. And so what are the things right now that are most important to you if your health situation were to worsen?
Well, I would like to spend as much time at home with my family, and I still have my poker buddies. I can't go to their house anymore, but they can come to my house, and my wife's been good about being the hostess month after or week after week. So those are, you know, spending time doing what I like to do. I've got some grandkids. I'd still like to show them how to do a few things.
Yeah. So I appreciate you sharing that. I've heard you just say how important your family and these relationships are in terms of meaningful time with them, but quality time, doing things
Exactly.
that you like to do, poker, enjoying time with the grandkids. I appreciate, again, you sharing that. And what are your biggest fears and worries as you think about the future with your health?
You know, I don't want to be a burden on my family. I want to be at home. I don't want to spend too much time in the hospital. I definitely don't want to be in a nursing home. I think that's would be my number one fear.
Mm-hmm. Well, that's important for us to hear. Again, along the lines of how important your family is, you worry about burdening them or not being there with them at the end of life and being in a nursing home. And aside from your family, or what else gives you strength as you think about the future with your illness?
I've got a lot of church friends. I've got a strong faith, and they've been very supportive. And you know, my faith will be there with me all the way.
Mm-hmm. Seems like that faith gives you a lot of peace, a lot of strength.
That's right.
And as you think about your life, what abilities are so critical to you that you can't imagine ever being so sick that you would have to live without doing?
You know, I want to be able to bathe myself, take care of myself. I mean, I don't want other people to have to do that. I've had to give up some things that I was the main person doing, like shopping, but you know, I want to be able to take care of myself and be independent at home.
Mm-hmm. I know you really value that independence. And if you did get sicker, how much are you willing to go through for the possibility of gaining more time?
You know, the last time in was rough enough that I said I'm not ever going back to the ICU again. But I think I would be willing to go back to the ICU.
Mm-hmm.
I'd be willing to go back to the hospital, but I'm not willing to go on one of those ventilators.
Mm-hmm.
I'm just seen too much and heard too much about that.
Yeah. Well, again, I appreciate you being open and talking about that with me, because that's a really important thing for your medical team to hear and for us to honor and respect. And I hear you say, treating things that are reversible, even going to the hospital, if the doctors feel like they can get you better, that you would be willing to put up with that and go through that. But if you were ever so sick that your body was dependent on life support, that wouldn't be a quality of life you'd be okay with.
I think that word reversible is really important here.
Well, I appreciate your honesty and being open to talk about that. And how much does your family know about your priorities and wishes? You've shared how important they are to you. How much are they aware of your values and your priorities?
I think my wife thinks she knows more than I do about everything, but I'm not sure that exactly where she is on this, because we really haven't talked with her much. It's one of those things that's hard to talk about.
Absolutely. And we hear that so often. These are not pleasant things to talk about. Hoping for the best, but planning for the worst. That can be really difficult and overwhelming. Well, I've heard you say your family's so important to you. Being independent, spending meaningful time with them is important. But that also you'd worry about being so sick that you were in the hospital and they were recommending things like life support. Based on what you've shared with me and keeping that in mind, what we know about your illness and how sick you have been, I really recommend that we include your family and your wife in our next visit to talk about some of these things. I think it's really important that she would be able to advocate for you and understand what's important if and when you did get sicker. How does that plan seem to you to include her?
I think that's a good idea. She's hard to listen. She doesn't like to listen, but she needs to listen.
Well, please know we're here for you, we're here for her, and we're going to support you through this and help with that conversation and help ensure that she's hearing what we're saying, but also asking questions and helping support her through this, because this can be so difficult. And please know that I'm going to do everything I can to help you through this and be here with you every step of the way, okay?
Thanks, Doc.
Yeah. I appreciate you taking time to do that today with me.
It wasn't as scary as I thought it might be.
That's good to hear. All right, cut, end scene. So, again, we just role-played start to finish using the conversation guide itself. I'd like for you all to please share comments in the comment box. Provide some feedback for us on how that went. And so what did you see? What are some strengths of having these conversations? What are things that you worry about as the clinician? Any comments about what we just demonstrated for you all? And Laurie will share with them here on the stage, and we'll kind of address those as they roll in. So please feel free to give us any feedback at this point. One of the questions right before we cut was how long these conversations take. And so that was one thing that we would hope to demonstrate in doing the complete conversation start to finish, is that the guide, again, allows us a tool to stay on target so that we can be efficient in these conversations. And hopefully we demonstrated to you all, again, that this conversation doesn't need to be more than 10 minutes, 5 to 10 minutes. And so we hope that was something that you all were able to see there. And again, if there's any comments, we're happy to address those. Otherwise, we'll prepare to now pivot and transition to other scenarios. And at this point, when we do the conversations, we'll do a little more stop and start and highlight teaching points throughout the conversation and focus on some communication skills techniques to help clinicians have these conversations. So before we do that, any last chance for any comments? All right.
Good morning. It looks like we've got some comments about thanking for creating this cheat sheet to stay on point and having these difficult conversations, and then trying to have the schedule and scheduling in time for just these conversations as well. There were some questions about when and timing of diagnosis to have these questions. I think we can answer some of those after we do some of the role play. At present, what we're going to do is we're going to move to having Dr. Haley Carter and Dr. Chris Hawk act as the patient and provider having the conversation, and Dr. Ritchie is going to move to the moderator to point out some of the conversation pieces and communication tips and tools, similarly to what we do in person on the one-on-one role playing, that is also still available as well. So we're going to go back to those folks for the role playing observation.
Great. So at this point, we really are going to role play and demonstrate again what these training sessions that we offer look like in real time. I will be a moderator. Dr. Hawk will start off as our clinician. Dr. Carter will be our patient in the first scenario. Again, I will be jumping in and out throughout the conversation. We'll pause, we'll reflect back on what you all are hearing, what we're saying, and we really hope that this part of the session this morning is interactive. And so when I pause, I'm going to ask you all in the audience to give me your feedback, share what you're seeing, so that we can focus on teaching points and highlight the things that are going to be going really well on stage, I'm sure of it. Again, I'm going to step off to the side, and this is, again, mirroring what we do in these sessions that we're going to offer after today. If you're interested in doing the one-on-one session and practice being the clinician, this is how that would go and how it would look. And so, Dr. Hawk, do you want to take it away and describe the scenario for us?
Thanks. So Mrs. Carter is a 53-year-old wife, mother, bank teller. She wanted to be a casino pit boss, but that wasn't available here. She unfortunately was diagnosed with stage 4 pancreatic cancer on our last visit 3 months ago with a solitary liver metastasis. I referred her to an oncologist, and she's been getting chemotherapy, and her first CT scan recently showed some improvement in the liver metastasis. This is her first visit to come back since I saw her and gave her that diagnosis. So, Mrs. Carter, how's it been going?
Well, I finished up the chemo, and I'm actually feeling a little bit better, so I'm encouraged.
That's great. That's great. And you've heard about your scan?
Yeah, it sounds like things are shrinking, getting a little smaller, and so I think I'm on the road to beat this.
Good. So I'd like to do something a little different today. I'd like to talk with you about what's ahead with your illness and think about what you would want so that we can give you the kind of care that you want as things go forward. You're going to be seeing your oncologist a lot of the time. I'm always in the background, I'm always available, but I would like to talk right now to find out about that. Is that okay?
Well, I mean, like I said, I'm really feeling pretty good. Do we need to do all that? I thought I was just coming in to just kind of go over medicines. And
Well, we'll talk about your medicines at the end, but I really like to talk with all of my patients when they've got a significant illness, kind of at the start, so we know what's important to them as things go along. Is that okay?
Well, I guess that makes sense, sure.
Okay. So what's your understanding about where you are with your disease?
Time out. Pause. So, Dr. Hawk, how's that going?
I think it's going okay. I mean, I expect patients to be hesitant or rebuff a little bit, but I thought we transitioned pretty well.
I agree. And Dr. Carter, what's he doing well? What did you see?
Well, I feel like you're using empathic statements. You're really understanding where I'm coming from. You're being supportive. You're here to, you're giving me as much information as you can, kind of explaining step by step.
And one of the things that I saw is at the very beginning you were prepared for some pushback. And so that's one of the key takeaways from these conversations is being prepared at the onset to defend and define why we have these conversations and how important they are. And one of the things you said I thought was so important was I do this with all of my patients. So really normalizing that these are conversations that are valuable and that are meaningful to me to help take care of you, I thought was a really nice way to help align and kind of disarm a little bit so that you're willing to have the conversation. Any other thoughts or comments from the audience of what you all saw at the beginning there before we continue on? And if any comments come up throughout, please just feel free to type them as we're going, and then when we have these timeout sessions, we'll catch up with any comments that may have been added while they were practicing. Dr. Hawk?
We're going to get into in just a minute talking about what the prognosis is, and that's kind of the one thing that I think it's good to do before you sit down with a patient, is think about what prognosis you're going to tell them, because all of a sudden you don't want to look down at your sheet and say, well, should I take 1, 2, or 3? I mean, I think it's good to know ahead of time.
Yeah. I appreciate you sharing that. That is such a key takeaway. I hope you all heard what Dr. Hawk shared there is really with this conversation, the only pre-work that we need to do as a clinician is knowing the patient encounter we're going to go into really beforehand, rationalizing in our brain, well, which one of these 3 prognosis statements fits the most with my patient, or would I feel more comfortable sharing? And so that's a great point, because that's really the only pre-work you need to be ready to do. When you sit down, be prepared and know which one you're going to transition to. So I'll let you catch back up there, and we'll go through the prognosis and see how things go from that point on.
So what is your understanding about your disease and where you are with it?
Well, I know I have pancreatic cancer and that it had spread before we found it, so I know that's not good, but like I said, my scans are showing some improvement, so I think I'm doing okay.
How much information would you like from me about what might be ahead?
Oh, well, I want to know what you know. I want to be prepared.
Well, let me just explain to you that you are a responder, and responders do better than non-responders, so that's really good. Mm-hmm. But we also know that when people die of cancer, almost whatever kind it is, the last 1 or 2 months are pretty much the same. There's this uncertainty. We don't know how much time you have between now and when those last 1 or 2 months would be. That's the difficult part of cancer.
Yeah, I'm a planner, and that does make it hard to plan.
And that makes it difficult to hear. So I know this must be not really what you wanted to hear.
No, I thought I was like different than those other people. I thought I was the one that was going to beat this, and this is not good news. This is not what I was expecting.
Well, we know that you're a responder, and we know that people who have a positive attitude do better than those who don't, and you've got a positive attitude, so I think we keep working towards putting you in the category of patient who does the best. We don't know what the best is. Let's just hope that the best is really good. We worry that it's less than we want, but we're still hopeful that it's going to be some long, productive time.
Good. Thank you for sharing that with me.
All right, time out, pause. All right, so Dr. Carter, how's that going?
Well, I think it's going okay. I think he's giving me the news and still being positive and knowing and responding to how I respond.
Yeah.
So knowing me as a patient and knowing what's important.
And Dr. Hawk, what were you picking up on as you were sharing that information? What were you seeing Dr. Carter's response was?
Disappointment, and maybe a kick in the teeth.
Right.
You know, it's upsetting news to hear.
Yeah. And so, this is the point of the conversation that we train our clinicians and we practice using different empathic statements. And so in our training sessions, we'll go through different strategies and ways to name emotion, to share statements of understanding, respect, support, or even exploring the emotion that you're seeing. So maybe we can try to use one of those now and see how that goes. So is there one of those types of responses that you may want to try? How about
On the same part?
Yeah, we'll do it at the same part. Maybe we can start with the explore question or empathic statement. So tell me what you're thinking about or what's going through your brain. So some statement to just put it back in our patient's lap to really be able to share with us what they're thinking, whether that's you're scared or you're mad or whatever it may be, whatever emotion this is eliciting from you. Maybe asking, tell me more about what you're thinking, may be a way to transition into our next section. Can I give that a try?
Sure.
Great.
So I know that wasn't what you wanted to hear, but Ms. Carter, what are you thinking?
Well, that's just really scary to me because not knowing how long I have and thinking that it might be short, I have a lot of big plans coming up and things that are important to me with family and now I'm just not sure how I'm going to feel for that and if I'm going to be able to make it.
I hear you, and that's one of the uncertainties of cancer, and I think it's going to be important that you plan important activities with your oncologist so that your treatments interfere as little as possible with what's important to you.
I think that's a good idea. Thank you.
So thinking about your illness, what is important to you? And
Well, like I said, I have a very close-knit family. We like to take trips together. We like to eat out together. We have a lot of get-togethers, and I really want to feel good and be able to take part in those activities.
I hear your family is important, and I see a lot of things there that you could keep doing. Trips are going to take a little bit more planning, but I see a lot of things you could keep doing. Are there fears or worries that you have as you look forward?
Well, I want to be strong. I don't want my family to see me really sick, and I don't want them to have to take over and do everything for me. I want to be independent.
I hear you. You've been the strength of the family, and you want them to still see you in that role.
Right.
So what gives you strength as you think about your illness and going forward?
Well, like I said, I have a close family, but I feel like I've gone back to work and have that part of my identity, and I feel like I take as good a care of myself as I can. So I'm hoping that will carry me through and help me stay as well as possible.
I certainly hope so too. And once again, that's a little bit where the uncertainty is.
Yeah.
What abilities are so important to you that you can't imagine living without them?
Well, I love the outdoors. I like to sit on my back porch. I like to be able to get out and get fresh air. And I don't want to be confined to the bed. I don't want to be in a nursing home. I don't want my family to have to do everything for me. So I guess really independence and being able to move around.
Thanks for sharing that. And I hope you share that with your family as well. How much are you willing to go through to gain additional time?
Well, I want to have good time, but I don't want a lot of things that are going to cause a lot of pain and make me very uncomfortable. I can stand a little discomfort, but I just worry about pain. My mom had a bad experience at the end of her life and was in a lot of pain, and that just was hard to watch. I don't want my family to have to see that, more so, even than me. I just don't want to have a lot of pain that they're worried about.
I'm glad you mentioned that. Pain is important, and when we've done studies on cancer patients, we've found that pain is one of their greatest fears, and yet so few people are willing to express it as you have. So thanks for sharing that. We will do everything we can to control your pain, but it's also important that you tell us when you're getting it so that we can start with appropriate treatment as early as possible. How much does your family know about what we've talked about today?
Well, They know I have the cancer, but they think like I said, when I came in, they think I'm doing pretty well with it. So I'm not sure that they're aware that things could take a turn like you described, and that we just don't know. So maybe I guess I need to be sharing that with them.
I think it would be important for you to share your conversation with them. I thank you for what you shared with me. I've learned that pain is important and we need to be sure to work on that. It may be helpful to have your husband come in so that he can hear this. You need to talk with him, but it's sometimes helpful to hear it from the doctor as well.
Sure. Yeah.
And I want you just to know that we'll be with you every step of the way. You've got other doctors, but I've been your doctor for the longest time, and I want to be here for you as much as I can.
Well, thanks for having this conversation with me. I know I really wasn't looking forward to it when we started, but it's hard to hear, but I think it's all necessary information, so thanks.
Good. Now, on your medicines, which is the only thing I think we have to talk about, you should continue these 3 and...
Time out. So how's that going?
I think it was a little rough, but I thought we got through it, and I think we covered it, and we found out some important information, for example, about the pain, and we found out their family doesn't know too much.
Yeah, I thought you did so well. I think a few of those things were really critical for you as the clinician to, enforce your recommendations, right? And where we go from here. And along those lines, Dr. Hawk mentioned some of them, but what were some of the things that you were sharing at the end there that he picked up on when he gave his recommendations statement? I heard 1 or 2 areas in particular. Do you remember what you had said?
Well, I am worried about pain and my family seeing me, weak like that, and I don't want that. And so he said he'd make sure to manage it. So I think that's great.
Right. And so that's just to highlight the end of this conversation is where we get again to be the clinician and summarize what we're hearing. And so we can take this conversation in any directions that our patients give us. It may be as straightforward as hearing from our patient that my biggest fear is pain and suffering at the end of life. And so one of the, it's kind of what am I thinking, but do you remember when she shared that she was really worried about pain, do you remember by any chance what you said just naturally in response to that?
Well, I thanked her for sharing that, and then I told her that pain was a very common symptom that cancer patients were afraid of.
Right.
And it's a lot easier to answer that question on a quiz than it is when the doctor asks you in person.
Yeah.
And
you absolutely
for you to be able to say it.
Right.
But pain is important.
Right. And Dr. Hawk normalized, what he was hearing with some active listening even, being able to repeat back what you're hearing can be a really powerful tool to let the patient know that you're engaged, you're paying attention, you're listening. You also said a really powerful empathic statement of, I'm going to be here with you every step of the way to help manage this pain. And so you said this line of support, which again, it's built into the conversation itself, so that if you're having the conversation with the patient and it doesn't come natural, we end the conversation with, I'm going to be here to support you. But that was a really elegant way to have an empathic statement when she just shared something that she was so worried about. And so I thought that was a great example, again, of using a support statement. There's so many that we can practice using when we have these conversations and that we can work on in our skills sessions. Again, everything from naming the emotion, some sort of statement about, thank you, this helps me understand where you're coming from and what you worry about, to support, I'm going to be here to help support you. And so I just wanted to highlight such a well job done there with adding that comment. So we've just gone through a pancreatic cancer type situation. We've gone through a COPD type situation. Are there any comments from our audience about anything that y'all have seen so far or would like to jump in before we pivot to another scenario? And again, it looks like there's none in the box at the moment, but as we're doing this, please feel free to drop comments. We'll stop in intervals like this and address anything that's in the comment box. Anything before we switch roles? And Okay.
I think I'm
Well,
good.
we're going to switch it up here. So for our next situation, we're going to switch our doctor and our patient roles. Dr. Carter, you want to share what this scenario is going to be for us?
Sure. Mr. Hawk is a 72-year-old gentleman who is husband, retired barber. He has congestive heart failure. He's had a recent echo revealed an EF of 15%. He's had 2 hospitalizations already this year and has just been referred for home oxygen. This scenario is taking place in the Advanced Heart Failure Clinic.
Okay.
And he also has recently learned that he's not a candidate for advanced heart failure therapies. So, hey, Mr. Hawk, it's good to see you here out of the hospital. How are things going?
I'm glad to be here, but carrying this oxygen around is no fun. And I thought that was just for people with lung disease. So when I found out I had to carry oxygen, that was upsetting.
Yeah, I bet that was really confusing. There are other situations, and heart failure, as you know, has given you some time with more shortness of breath, and that must be hard to deal with, though.
Yeah, being short of breath and having to think so carefully about what you want to try to say before you started.
Wow, that must be a change as things are getting harder. I'd like, if I can, to take some time today to talk about what's ahead with your illness and find out what's important to you so that I know the best way to care for you. Would that be okay?
I think that would be good because when I was in the hospital, the cardiologist just didn't really talk about that. He just said, you can deal with that with your primary care doctor, or we'll get to it later. But so I think it'd be good.
Yeah, I can't imagine how frustrating that is to feel like you're not getting all the information, and I'd like to help with that.
Yes, that would be helpful.
Good. Well, if you don't mind, I'm going to be using a guide. I do this with all of my patients. I like to make sure that I am having these conversations and talking about things as they are going along so that I don't miss anything and that I cover things and like I said, find out more about how to treat you. Is that okay?
Yes.
Good. Well, tell me right now, what is your understanding about where you are with your illness?
Pause, time out. So how are things going so far?
Well, he's been able to tell me a lot of things about how he feels about this, and I'm trying to respond to those.
Absolutely. And what are your thoughts about her normalizing the guide itself? How did that go?
I think that's good. As a patient, I have no idea about a guide. So I think to normalize it makes sense.
Absolutely. And we encourage people to actually physically have the conversation with them and reference it so that we get the wording right, we don't miss anything. But if we do that, it can be a little disconcerting if we don't explain that to the patient, right? If we're referencing the sheet and they're looking over saying, what is that? What are they doing there? And so if you are going to use the guide, we definitely recommend, just as Dr. Carter did, physically referencing it, saying, I've got this conversation in front of me. I'm going to be reading this. And I hope you all would pay attention and focus as we go through this. We've really done it in all 3 scenarios, but how natural or unnatural it is going to come across as we read the conversation. Because we want to circle back to that at the end to get your thoughts on that. Because without practicing it, a lot of people worry that it would never seem natural if I had a sheet of paper in front of me and I was reading questions. But we hope to demonstrate and role play and practice that it can actually be very natural. And in fact, referencing it can be a way to engage with the patient so they know what you're doing. So I appreciate your comment there. I thought that helped set the stage really well.
Also pointed out that I hadn't done it.
Right, yes, yes. And before I step away and we get back in, now's a good time too. We can regroup. And which prognosis statement do you think would work best in this situation? Which one would you prepare to use?
I think in this situation, I'm going to use the function statement because that's kind of a little bit more general. It doesn't tie me down to time or that kind of thing, and it lets him know how things might go from here.
Absolutely, absolutely, especially with like the recent oxygen referral and things are getting a little more difficult in terms of quality of life. So, well, great. Well, we'll prepare to do that one, and I'll get out of the way, and y'all can jump back in.
Okay. All right. Well, what's your understanding now of where you are with your illness?
Well, I've got congestive heart failure, but I've had it for 8 years. But now I'm on oxygen. That's a bad sign. And I guess I was always hoping that there was going to be something out there that they could do for me, like this left ventricular assist device that I know some people have had. They told me that's out. So all of a sudden I'm thinking, I'm on oxygen and there isn't too much else that can be done. So I'm kind of worried that I'm getting closer to the end.
Wow, that must be very scary.
It is.
Yeah. And thank you for sharing that with me. That helps me provide the best care for you, knowing how you're feeling about these things. How much information about what's ahead would you like to hear from me?
I think I would like as much as you can give me, Doc, because once again, when you're in the hospital, it's really hard to get information about what's going to be happening when you're at home.
Yeah, that's just a lot of unknown to have to deal with, isn't it? Yeah. Well, I want to share with you my understanding of where we are. And I hope that this is not the case, but I worry that this may be as strong as you're going to feel and that things may get more difficult from here. Does that come as a surprise?
Yes and no. Yes, in that, you know, it's always a surprise when you hear bad news, and no, in that I knew it was coming, and I guess I knew it was going to be bad when they told me I couldn't do those advanced heart failure treatments. So
I'm
it's
really
still difficult to hear, though.
Sure, and I'm really sorry. I'm sorry to have to share that with you, and I'm sorry for what you're going through and how scary that must have been when you got, just listening to this. Knowing, hearing what we are talking about and hearing what may happen, can you share with me what are some things that are most important to you going forward?
Pause. I'm going to jump back in. So how did that section go for you?
Well, it's tough to deliver that kind of news. So, I think he was took it very thoughtfully and was able to give me good feedback.
Yeah. Well, I picked up 2 or 3 different empathic statements and ways that you responded at such a critical moment. Dr. Hawk, do you have any thoughts on that, or did you pick up anything that she said or did, or any of her actions when y'all went through that section?
Yeah, I mean, she's obviously listening carefully to what I say and supporting me in terms of where I am emotionally.
Yeah. And one of the things I could feel, listening in on the conversation was a deliberate pause after you shared the line. And again, that's such a powerful tool to be able to just stop in the conversation and let what you shared stay in the room. And then do you remember, after the pause, do you remember how you transitioned out of that silence? Do you remember what you said?
Did I ask him, is that a surprise? Because he seemed genuinely,
Yeah, and that's a really skillful question to ask, that we can learn a lot in that simple question. Because we always joke that there's only one expert in this world on you, and that's you, in terms of when we talk to our patients, and they often know what's happening with their bodies and their illness well before their medical team. And so a way to explore that is just to ask someone, are you surprised at what I just shared with you? And it could be everything from disclosing a new diagnosis, scans come back and show cancer, or heart failure or even prognosis. But does that surprise to hear you? And Dr. skillfully said, well, yeah, it's hard to hear, of course, but that didn't really surprise me. I'm the one feeling this. Things are getting tougher. I was worried that this may be as strong as I feel. And so that was a really skillful use of that surprise question. And I'd encourage people to maybe think about ways to incorporate that again in y'all's encounters. Anything else to add before we jump back in? All right. Well, we can start at the explore questions right at the top
Okay.
there and
Sure.
pick it up from there.
Okay. So what are some of your important goals or what's really important to you as your health situation might be worsening?
Well, I want to spend time with my family, particularly my grandkids. I love telling them stories about things that happened in the barbershop, and like when I cut Bill Clinton's hair on the airplane. Have I ever told you about that?
No, my goodness.
Well, it was in the newspaper, but I wasn't the one who did it. But I have told about it. But I fooled every one of my grandchildren on that story, and I want to, I just want to spend time with them. I just want to be a granddad to them. And so I think that's really the most important thing. And I probably can teach them a thing or two.
Well, I hear you saying how important your family and especially your grandkids are to you, and that talking and telling stories is important. And you mentioned earlier that you have to now, with this being short on your oxygen, you have to plan what you want to say, and so that really helps me understand a lot about that and about you and what's important. And we're going to work on that and making sure that your breathing is as easy as possible so that you can tell those stories with your family.
Thanks.
Sure. What are some of your biggest fears or worries as your situation progresses?
I worry about becoming a burden. My wife is wonderful, but she's in her 70s also, and I'm bigger than she is, and it's just, I don't want to be a burden on her. I don't want to spend all day in the bed. I want to be able to get up, and I don't want my grandkids to see me suffering and miserable. I want them to remember me in a good way.
Sure. I hear you saying, again, that family is important, and you want to be able to have good times with them and not be a burden and not have tough things happening with them. And thank you for sharing that. What about what gives you strength as you go through your illness?
Well, obviously my family gives me strength, but also my faith. I mean, I know where I'm going. I just don't want to get there too soon.
Yeah, I'm glad you have your faith, and that hopefully gives you comfort. But I hear what you're saying. What abilities are so critical to your life that you just can't imagine living without them? You've mentioned some things you like to do with family, but what other kind of things are important to you?
Well, I like to get outside and walk around the yard. I don't take care of the yard anymore, but I still like to walk around it. But I can't imagine living if I couldn't take care of myself. I wouldn't want to be where somebody else had to do those things for me, and I couldn't get out of bed.
Yeah, that's good information. Thank you for sharing, because that helps us plan ahead for what you might need to help you keep going. And if you've mentioned your wife is maybe not able to do that for you, that helps us make plans about what are the things we can put in place to help you.
Good.
If you become sicker.
Pause. I'm going to jump in. Mm-hmm. So how are things going at this part?
Pretty good. His story's pretty consistent. I'm able to follow it.
I was going to say, Dr. Hawk wins with the Best Patient of the Day award. So from your perspective, how were the transitions from questions to question going? How did that come across to you as the patient?
Well, number one, she's using the sheets, so I know that there's a format, but I think the transition is smooth. So, I mean, it's not coming like we're going in a completely different direction. We're following a roadmap that makes sense.
Yeah. And one of the strategies, Dr. Carter, you're doing so well, is this concept of active listening. And so being able to hear our patients, what they say, and then reflect that right back to them of, I heard you say this, or this seems really important to you, or some comment that shows them that you're listening, that you're engaged, you're paying attention. And that can be a nice buffer to regroup yourself and figure out, how am I going to get to this next question? And so after each one, kind of reframing what you're hearing, and then using that to pivot to a next question is a great way to stay on track and be efficient with the conversation. So I think that's a great strategy to move on from question to question. All right. You going to jump in at the bottom? And we'll...
Yeah. Well, I have one more question here I want to
Yeah,
ask and
for
explore,
sure.
if that's okay. How much does your family know about your wishes and what's important to you as you get sicker?
Well, we never talk about it just because I'm a guy and we don't talk about that sort of thing. And she's never in the room when the doctor comes by because he comes so early. So I'm not really sure what she knows, kind of period. She thinks she knows everything, but I'm kind of concerned that she doesn't know really where we are.
Okay. Well, thank you for sharing that. I think that's important because you shared with me how important your family is to you and not being a burden to them. And I think it might be helpful if we could get your wife involved and any loved ones involved to kind of know where you're coming from and what your wishes will be. Our office has paperwork called advanced directives that's something we can think about too.
Okay.
So I know that family and being with them and not being a burden is important to you, and keeping that in mind and what we know about your illness, I recommend that we get your wife and family members here and maybe include them in our next appointment, and then also maybe work toward getting some of your wishes and important things down on paper so that they'll know. Does that sound okay to you?
I think that would be good, just so that everybody's on the same page. Thank you.
Well, sure. I want you to know that we're here for you, and we've been, you're caring for you for a while, and we're going to continue to care for you and your family, and we're going to help you get through this as best we can.
Thanks.
Sure.
All right. So how did that go at the end there?
I thought it was fine. I mean, I think the conclusion is good. Everybody in the family needs to know. Advanced directives are important, although that's kind of controversial in the last few weeks about whether they're really that beneficial. But, it's helpful to have thought about it for certain.
Yeah. And I think it was a good example. We've kind of done that once or twice today already, but the utility or the power of having family involved in the conversations, whether that's just inviting them into the clinical space the next visit, or it's more objective, we need to sit and document something with them so that we can do advanced directives. Or our recommendations could be clinical. Earlier we spent some time saying we're going to focus on your pain management, and that's going to be something I incorporate in your care plan as a top priority. Now that I've heard that's something that is most important to the prior patient. So I think that it was a few different examples today of where we take this conversation and where we really go from here. We've been asking for comments throughout the three examples, and so we'll see if there's any comments at the moment before we kind of debrief from a bigger group and talk about next steps in terms of our care program and our training sessions.
So we've got lots of positive comments, but we also have that someone noticed that the patient's concerns are noted but not really necessarily addressed specifically.
And that's, I appreciate that. We appreciate that feedback. One of the things that we haven't spoken of at this point is how do we strategize around staying on task? And not that we have an agenda or that we're not going to acknowledge a patient's concerns, but how do we communicate to be efficient, get through a conversation, but also acknowledge and ensure that we return to a patient's concerns. And so one of the strategies with communication we use is this concept of a parking lot. And so someone saying out loud, and one of our examples was, do we really need to talk about this? I I came today just to get my medicines refilled. I want to talk about my medicines. And so a strategy of saying, I hear you, you're talking about your medicines is very important. That's something we're going to ensure we do today. We're going to come back to that. I promise we won't miss that. I hear how important that is to you. Before we talk about that, I'd like to ask you these questions. And so being able to put something in a parking lot to come back to is an effective strategy to, again, align yourself, acknowledge that someone has a concern or they have their own agenda that we want to stick to because they have the autonomy, it's their encounter. But also being willing to reframe the conversation so that you can come back to it later is a powerful way to be efficient and stay on task. This often comes up too as we practice these conversations and even do them in real life. When you get to goals or fears, a lot of people will really go down like a cognitive road and want to talk about symptom management or some new clinical trial or a medicine, and they really want to take the conversation down a very specific road. And so using a parking lot concept is a strategy to help in the middle to reorient the conversation as well. You just shared you want to know more information about this clinical trial. It's clear to me you're willing to do everything possible in the hopes of having more meaningful time. That is something that we'll address and come back to. That helps me understand how important pursuing every treatment option is to you. And then you pivot back into the conversation. And so those are just a quick strategy to acknowledge concerns that we hear, but also stay on task in terms of making sure we don't miss things with the conversation.
As the patient, those things that we've put in the parking lot, I want to be addressed before I leave this visit. And if I've asked about a clinical trial or something, it's unlikely that the primary care physician is going to know about the clinical trial. And some of these, and maybe all of these questions, or many of them, are going to have to go back to the specialist. So the doctor really needs to say, I'm going to communicate with your oncologist or your cardiologist your concern about the possibility of being on this clinical trial. And that, to me, is probably the best that I can do as the primary care doctor.
Yeah, and that's so valid. I think the takeaway is that we by no means want to come across as not acknowledging patient concerns, right? So we want to acknowledge what we hear, but we do want to be able to reframe it. And goodness, if a conversation, something we should add here, sometimes these conversations don't start and stop and complete the whole conversation in one sitting. Sometimes it's not a one-size-fits-all. Often these conversations are broken up over 2 or 3 even visits. And so there may be a conversation that you're engaged in that after the first question, something really does need to be addressed, or you really do need to take time clinically to focus on, and that's completely okay. Today we've tried to make it a little more clear-cut just to get through, but please know this conversation can be an evolving conversation over multiple visits. And another point along those lines is we really want to emphasize that this conversation is going to symbolize just one point in time, right? So today, with your illness, in this situation, this is what's most important to you. This is what you worry about. We fully expect that the answers to these questions will evolve and will change. And so the same conversation can be had multiple times with the same patient. This isn't an advanced directive. This isn't a code status that we had one conversation and we locked it up over here and never came back to. This is really a framework to engage with our patients on a more meaningful level about values and wishes, knowing that we've got to come back to this, and things would certainly, we expect to change. So I appreciate, again, that comment. Those are some good discussion points. Okay. Well, at this point, I think, thank you all so much for joining. We're going to kind of wrap up the last few slides here, and as we go through kind of next steps, if there are any other questions, by all means, please drop them into the comment box, and we'll go from there. So some of the larger topics we want to debrief on, if you do have comments, again, things to think of in the audience. So any gut reactions to the conversation guide itself? Are there things that you found useful to the guide? Are there things that you think you would struggle with, or that even visually watching it today, you still are worried about? If you have thoughts or comments to any of these questions, by all means, please drop them in the comment box. That'll be really helpful for us, and we'd be happy to spend some time to focus in on that, okay? While you may be collecting your thoughts and dropping in comments, we do want to highlight, again, take a step back and highlight some of the specifics about this conversation and how do you document this? And we had this great encounter in the office, but what do we do with all of this information that we just got? And so right now, as things stand today, we want to inform you that there's templates within our EMR, within ECW and within Cerner, to document responses to these questions. And so you can see here in ECW, this is going to be a template under the HPI section. It's titled Serious Illness Care Conversation. And so when you click on this template, it pulls up the questions that we ask. There are going to be the most often answered responses are auto-populated that you can check and highlight if the patient responded in that way. But we also always encourage people to free text, comment, type in a narrative about what a patient answered. But just know a lot of themes come up with these conversations that are recurring. And so within the templates for ease of documentation, we put those in there so that if the patient's worried about their finances or their symptoms or being a burden on family or spending time in a nursing home, those options are there in the document that you can easily highlight and save you some time on the documentation piece. Also at the bottom of these conversations is going to be an area for a timestamp so that you can get credit for face-to-face encounters and advanced care planning with our patients in terms of reimbursing documentation within the EMR. And then one of the final things here is, I've said over and over throughout the morning that the sessions that we practice and we role-played here, we offer those one-to-one with our clinicians in the health system. And so we set up time, pre-pandemic, we're doing these in person. We've pivoted to a virtual platform, and that's evolving based on what's safe and what's right. But please know that we're happy to spend time with clinicians, practice using the guides, kind of like we did at the end there, stopping and starting, letting you redo questions, ask them a different way. We think of these sessions like any other skill set. It really takes muscle memory, and we need to practice before we go, with a live patient and have these in the clinic setting. Our training sessions are made to be a safe space, right? Anything that says and is done in our sessions, we keep to ourselves. It's a place to do things incorrect or say things in a wrong way, right? We can correct ourselves, we can practice. And so we really try to encourage people to sign up for these sessions and practice using this guide. That being said, we have available the conversation guide itself physically in different formats. And so some people that go through our program like to have pocket cards and put it in their white coat or even their regular pocket. Some even make cards small enough to fit on a badge. I personally like the larger laminated copies. Some clinics will put those actually in the patient-facing either the waiting room or in the actual clinician room itself, and patients can have their own autonomy to read through this guide and look at it before they even see their clinician. I kind of empower them to, hey, what's this? What are these questions? Tell me more about this. But we'd be happy to share all of these resources with you. We'd love to work with you and your clinics. Come up with a way to design workflows that this makes sense for you, and then help train you and your staff to actually engage in the work. Our training sessions span everything from physicians to nurse practitioners, our social workers, chaplains. We really encourage anyone who is excited about this work to come to our sessions and practice with us. We know this is a team effort, and often these conversations aren't just the doctor and the patient. It's the whole support team. And a lot of that comes back down to how your clinic's designed and how your workflow is established that makes sense for you and your patients. So a lot of flexibility to make this work meaningful for you all. And we really encourage you and hope that you take time to be engaged and reach out to us and start having these conversations in your clinic. I should say we know that you're already having the conversations. We know that this work is ongoing, and we're proud of the quality of advanced care planning that our clinicians are already doing. The goal of while we're here today and what this project is about is to standardize that process so that our patients are receiving the same quality conversations across the health system. So with that, I'll pause and see if there's any other comments in the comment boxes. By all means, I'm happy to address those. And I've left my email address here. Anyone, please reach out to me directly. Again, I'm a physician here in our health system, medical director for our palliative and hospice program, so I'd love to spend time to talk to you all personally. But thank you all so much, again, for letting us spend time this morning with you. And with that, I'll turn it back over.
Well, thank you, Dr. Ritchie. That was very, very helpful. I would like to put my 2 cents in for the role playing. I know that kind of brings you back to medical school or your other training, and it's a little scary, and you don't want to put yourself out there for that. But it really is helpful to actually say those questions while looking at another individual, even though they're not a patient, is really helpful because, as he said, muscle memory is important. And at first you might stumble over the words, and then later you can see just how well they come off your tongue. I took this course in person, and I was with 2 cardiologists, and that was very interesting to watch our different approaches in just delivering the questions and in the way we listen. I found that I wasn't looking forward to the role play, but I think that it really was essential to my understanding of how to use this technique. And I encourage everyone to give them a call, email them, and set something up so you can take this to the next level. One thing we haven't done at my office is get them to come over and help us incorporate it in our workflow. And I think that's a really great idea because a lot of things you learn and you want to do, but you just don't start. So with that kind of help, I think you could incorporate this into your daily work. And so I encourage everyone to think how this would play in their day-to-day work with their patients. Thank you again. So as we go to the break, I invite you to please watch this very short video about the Roper Foundation. As I spoke earlier, the Roper Foundation funded this CME, and that's just a very small thing that they are involved in. They are involved in so many things in our community. Dr. Kelly in this video explains how we as clinicians can help to support their work. So please take the time to listen, and then we'll see you back here at 10:30. Thank you.